be your Cpap lecture, your continued positive airway pressure lecture. We are going to go over a couple of different aspects of the Cpap. We're going to talk about the goals of Cpap in the field, Cpap and its physiological effects, the actual delivery systems, different types of delivery systems that you might use, why we use it, the medical applications, and when not to use the Cpap for your contraindications. Cpap is basically to give us a more effective way to treat CHF and COPD patients, specifically during exacerbation. Okay, this is a way that we are able to stent the airway open, or all the way down to the alveoli level, in order to try to do good external respiration at the alveoli level, and also if we are giving medications, in order to try to get those medications down in order to open up those lungs as best as possible. Now, Cpap doesn't work by itself. This is a process that you might have to explain to the patient. Can make the patients a little claustrophobic, and this is also something that we have used after we have kind of tried to coach the patient's breathing down. However, we have that has been unsuccessful, and we also have some other clues such as adventitious lung sounds, history of the patient, and any kind of pharmaceutical measures that they may have already taken. Those are all things that we need to consider before we actually start the Cpap. When we're talking about Cpap and one of its advantages, obviously the big advantage is the fact that we're using the patient's own spontaneous respirations and breathing patterns while we're using PEEP. The only thing that we are doing is supplying that positive and expiratory pressure in order to stent the airway open, and we are trying to get that air all the way down into the alveoli, just like if we were taking a regular breath in order for adequate gas exchange. This is a little graph here that kind of shows that it's actually still the normal respirations or normal breathing pattern of the patient, just showing that there's a little bit more PEEP in order for that patient to get that adequate gas exchange in the first place. Alright, so why does oxygen pass into the blood? Well, basically this is all due to Henry's law. You guys hopefully have already watched your videos on your gas laws. That deoxygenated blood really has a lower partial pressure of oxygen than the alveolar air. This makes oxygen transfers from the air into the blood much more easier, just due to that pressure gradient, right? That pressure from low to high. Henry's law. Again, this just showing us how the air is moving into the actual alveolar sacs. You guys can look over that diagram that I've posted, but remember that this is all, the Cpap is usually 100% Henry's law. We're just kind of creating that pressure gradient in order for that adequate gas exchange to occur. Guys, this is showing you that even with the small amounts of PEEP, we are accomplishing quite a bit for our patients. When we actually increase that partial pressure, we're actually forcing more oxygen to cross the alveoli and get into our bloodstream. Excuse me. So even really small changes when it comes to actual PEEP itself is really making quite the clinical difference. Cpap. Guys, I'm going to go on my soapbox here for a second. I want you guys to understand that I love Cpap. Especially when I got out of paramedic school. When Cpap was first introduced to our system, we could only use it for certain disease processes. And there was a lot of medics out there that kind of realized the good of Cpap and started really breaking protocol, I guess, or breaking standard procedures, and giving this to patients that there was no protocols for. And I think that's really what kind of changed the protocols for us with Cpap, specifically with most of the medical directors and the medical control board here in town. Cpap will save somebody from actually being intubated. Okay, it's a very wonderful tool. It works very well. It's very efficient, especially if you guys are using it accordingly. And just like I said in that last slide, very little PEEP can really do wonders and help the clinical outcome of your patients. We are looking for that constant airway pressure when we're using it, right? We're using it to help kind of force the fluid out of the lungs, so kind of push it down in order to recruit that alveoli for patients that have left-sided congestive heart failure or possibly even a pneumonia. We're using it for asthmatics to kind of help deliver the medication a little bit better. But really, we can use this for anybody that is suffering from a low oxygen saturation. It works very well. It's a process that you have to kind of talk through your patients. I don't know if you guys have ever had the opportunity to actually put on the Cpap mask, but it is kind of scary at first, and you just have to reassure the patient that this device is there to help them. And really, once you kind of get them to try it and put that mask on, have them hold the mask themselves if they are able to, and really kind of adjust that mask. Once they kind of start breathing in, they will also realize the benefits of the Cpap machine itself. Okay, so really what we're doing this for is just for continuous, constant, positive airway pressure, right? That's what Cpap really is. And stable airway pressure is prescribed in order to reduce the work of breathing. Okay, and I think this machine is great. I think it does wonders for our patients. I think it takes away or it prevents the paramedics from having to do intubations for some people, and that includes the hospitals as well. The goal of Cpap is to increase that functional residual capacity, which is basically the volume of gas of air that is left in the lungs in order to help stent the alveoli open, so that when we do take that next breath in, those alveoli are already stent open, those capillaries that are surrounding the alveoli are already stretched out, and it kind of makes it easier for that oxygen molecule to cross into our system and offload the CO2. All right. It does distend the alveoli, presenting collapse on expiration with that continued positive pressure, specifically when you guys are setting that PEEP levels to whatever you guys feel the need for your patient, right? And it creates a greater surface area for that gas exchange. Like I said, that those alveoli are already stent open. They're already kind of fully inflated, so that the next time that we take that breath, that alveoli is already open. It stents open even more, kind of stretching out those capillaries that are surrounding it in order for that oxygen molecule to move over into our system to be used for energy. And it really does decrease the work of breathing. And I think the machine itself, it really is like a warm blanket for some patients, right? Especially if you guys are able to make the patient understand exactly what this machine is going to do before you guys are putting it on, right? And as soon as those patients kind of take those nice first couple of deep breaths, that work of breathing really goes down, because they realize how much that machine is actually beneficial to them at that point during whatever crisis they were actually dealing with at that time. So make sure that you guys are doing a really good job explaining this process to your patient. I know sometimes, specifically with Cpap, it seems like the calls that you are using Cpap on, it could be a little rushed, where you really feel the need that this is beneficial for the patient, or you know that this is beneficial for the patient, and I think us as providers really kind of rush that without actually explaining it to the patient. If your patient's alert enough to actually hold the masks hard against their face themselves, have them do it, and let them kind of take a couple of breaths in, explain to them how to take, coach them to breathe still, right, and explain to them what's kind of going on in their body, just as best as they can. And really the best way to explain it is that they're really kind of taking one of the better breaths that they have probably taken in days. And I think if you kind of put it that way to your patient, it does kind of put them at ease. I mean, the machine is loud, right? That mask is cumbersome, I guess, is the best way to put it. It can get them anxious, right? And we want to try to keep them from becoming more anxious by not explaining this procedure and just kind of trying to slap this mask on their face and forcefully holding it down against their face while they try to breathe in. Let the patient get involved with their own treatment, and I think that's kind of no matter what you're doing in emergency medicine or medicine in general, is if the patient's able to get involved, get them involved so that they can see the benefits for themselves. Guys, when we're talking about common complications with CPAP, I'm not going to go too much into this. I think that your respiratory guidelines really kind of lays out the protocols that we want you guys to follow when it comes to actually using the CPAP. But I am going to talk about a couple things. First off, we want to really kind of start low on our PEEP and work our way up. Obviously reassessing in between increases of levels of PEEP. Okay, in the field we usually start at about 5 centimeters of H2O for PEEP, and we can go all the way up to about 10 with the quote-unquote normal street medic. When we start getting into the actual critical care medicine, we can go up a little bit more, but that's besides the point. We're going to stay where you guys are at now. So let's say we got this little old lady, right? She's complaining of shortness of breath. We hear fluid in her lungs. She might be satting, we'll say, you know, I don't know, high 70s or something like that. We really don't have any wheezing associated with this. She's just got fluid in her lungs due to a history of whatever, CHF, okay? So we explain the process to her. We throw her on some CPAP, and we start off at PEEP of 5, right? And once we get her going on that, we've kind of coached her breathing a little bit, kind of given her some warnings of the expectations of what the machine might feel like. She starts kind of breathing at a normal rate again. Her respiratory rate might come down a little bit. And she's sat in, let's say, at high 80s at this point. So you guys decide to increase the PEEP, and let's say, you know, you move it up another 2.5, so you're at 7.5, and your sats are good, but your blood pressure is dropping, right? Well, the problem with that is the fact that because we are providing that continuous positive airway pressure with the PEEP, we are increasing the intrathoracic pressure in the thoracic cavity. And again, remember, when we increase that intrathoracic pressure in the cavity, we're actually kind of squeezing on the inferior and superior vena cava. It's kind of sensitive to intrathoracic pressures, so we're going to decrease the actual preload back to the heart. We're going to decrease the blood flow going back into the right atrium. If we decrease that preload, we can actually start kind of decreasing cardiac output as well. And if we could decrease cardiac output, we can decrease the cerebral perfusion, which is going to change the mentation of your patient. So we really kind of want to watch patients' blood pressures as well as we are working with the CPAP. You guys, I'm not going to go over the contraindications. Those are on your respiratory guidelines. But you guys need to make sure that even when you're on the CPAP, it is, for the most part, a pretty safe machine as long as you guys are staying on top of it and as long as you guys are reassessing your patient, right? And even when it comes to CPAP, you know, remember, we want to reassess. Anytime that you guys do an intervention, you guys should be reassessing your patient for the pros and cons of that intervention. And that includes adjusting the PEEP, guys, right? If you guys go up from 5 to 10, you guys definitely need to check out the PEEP, or I'm sorry, reassess your patient in order to see if that stuff is working. Guys, don't be afraid of CPAP. I think it's a really kind of, gosh, how do I want to put it? I think it is underutilized, I guess is the best way to put it, in EMS. I think that there's a lot of applications where we could use PEEP or Cpap, but we choose not to. And I really think that with most of our people that have some sort of respiratory illness, PEEP can be very beneficial for them. So make sure that you guys are watching the videos on this, right? Specifically on how to set up the neb setup with the Cpap machine. It's actually quite easy. I think it's a great video for you guys. And again, remember guys, these videos are available to you throughout the whole semester. You guys need to be watching these videos multiple times. Specifically the breath sounds audio files that I've put up for you. You guys really need to start looking at those lung sounds, okay? Start listening to those lung sounds in order to help you guys when it comes to scenario practice. Thanks again for joining me. If you guys have any questions, please feel free to email me, and I will get back to you as soon as I can. And we will see you for the next lecture. Thanks a lot.